Welcome back to Clinical Pearls in Practice, the podcast where we break down real-life cases and help you master the key points for your boards and bedside.
Well, today's case is about a 27-year-old white female with a history of mania who presents with polyuria and increased thirst over the past month.
Right. So she's been on lithium therapy, 1,800 milligrams daily for 3 years, and her mania has been well controlled. She hasn't lost any weight, there's no family history of her current problem, and importantly, she has no orthostatic blood pressure changes. Let's look at the labs. Her serum sodium is 145 milliequivalents per liter, potassium 4.5, glucose 92, creatinine 0.9, and her serum lithium level is 1.38, which is within the therapeutic range of 0.5 to 1.5. Urine studies show a 24-hour urine volume of 6.85 liters, and urine osmolality is 161 milliosmoles per kilogram H2O. Interestingly, there's no significant change in urine osmolality after administration of vasopressin.
So what's going on here? Let's think through the differential. Could this be diabetes mellitus? Well, the serum glucose is normal, so the osmotic diuresis we'd expect in hyperglycemia isn't happening.
How about central diabetes insipidus from a hypothalamic or pituitary issue? That usually responds to exogenous vasopressin, but in this patient, the urine osmolality doesn't change after vasopressin administration.
Psychogenic water drinking? Sure, psychiatric patients can do this, but it typically doesn't cause hypernatremia or impair renal concentration like we see here.
Exactly. That leaves us with drug-induced nephrogenic diabetes insipidus, which is actually quite common in patients on long-term lithium therapy. Polyuria occurs in 20 to 70% of these patients, even when lithium levels are therapeutic.
Right. Lithium impairs the kidney's ability to concentrate urine by affecting the response to antidiuretic hormone. So even if the patient is producing a lot of urine, giving vasopressin doesn't help, the kidney simply can't respond.
Key takeaway here, in patients on chronic lithium who develop polyuria and hypernatremia, think nephrogenic diabetes insipidus first. Monitoring kidney function and considering dose adjustment or alternative therapy can be crucial.
And remember, unlike central diabetes insipidus, this type doesn't respond to vasopressin. Management focuses on stopping or reducing lithium if possible, ensuring adequate hydration, and sometimes using medications like amiloride to mitigate the renal effects.
That's it for today's case. If you're reviewing for boards or just want to sharpen your clinical reasoning, remember the classic triad here: long-term lithium therapy, polyuria with hypernatremia, and vasopressin-resistant low urine osmolality.
Thanks for listening to Clinical Pearls in Practice. Stay tuned for more cases that sharpen your clinical thinking and help you crush your exams.